Hello, good evening, and welcome everyone again to another round of an amazing webinar on behalf of SigTuple. I welcome all of you who have taken your precious time to be here with us on this lovely Saturday evening. A little bit before I introduce our esteemed speaker for the day, just a few words about SigTuple. As we all know that SigTuple combines robotics, optics, and data science to create pertinent solutions in pathology, which can be used on an AI-based platform. Starting out with our flagship solution, which has been the peripheral blood smear and urine microscopy in clinical pathology as well. Let me move on now, which is the most awaited moment of the day when I have this privilege to actually introduce the esteemed speaker for today, none other than Dr. Rani Radhakrishnan herself, who is a glorious hematopathologist with more than 30 years of practice in laboratory medicine. She will be talking to us today about clinical pathology in transition, navigating the digital frontier. That's her topic. A little bit about her, like I already mentioned, she's been there in the field for more than 3 decades, right? And she's done her undergraduate as well as postgraduate training from the esteemed KMC Mangalore and DNB from Apollo Chennai. So ma'am has been quite of an inspiration in her own way, at least for myself. I've been bumping into her in conferences and seminars, and as I've been traveling across the country, and I have gathered so much knowledge in those short conversations when I have been talking to her. And she comes across, and she's very well known for designing a near zero error lab today and championing the automation as a tool for better diagnosis. Her zest for new technology and laboratory automation has driven her to understand them and use them for betterment of patient care. She's conducted numerous seminars and training sessions for pathologists, staff in the industry and in our fraternity. And most importantly, her mantra is, what the mind does not know, the eyes do not see. And that's something I'm sure that we will agree with her on this. We're very excited, ma'am, to have you. And thank you again for taking your precious time out to do this webinar for us today. I'm really looking forward to your amazing session. Over to you, ma'am.
Thank you very much. Thank you for this lovely opportunity. And it's really a pleasure to talk about clinical pathology. So let me share my screen. Yeah, I hope you can all see it.
Yes, ma'am, we can.
Yeah.
Good to go.
So the question that we're asking at the beginning of today's topic or today's lecture is clinical pathology really in transition? And are we navigating the digital frontier? Now, coming from someone who's been around like a dinosaur probably for 30 years, I've really seen a lot of change happening as far as laboratory medicine goes. There being so much of technology development in clinical chemistry, in hematology, in pathology, and so on, that this poor little clinical pathology got kind of pushed to the background. And I remember as a young pathologist, trainee pathologist, as a postgraduate, entering the labs and really not wanting to go to this dark, dingy room where urine, motion, and the likes were processed, because it was not one of those glorious places that one went and worked. And if you said that you're heading clinical pathology, it was not really a great thing. I have tried to recreate the clutter over here, but, I'm not able to do that. So this was the lab there where we did manually all the tests. You did manual microscopy. There was mix-up of samples. You didn't know what you were doing, whether Rothera's test was correct or Benedict's test was correct. But that's what was happening over there. About a decade or a little more than that, there was this disruption. And this disruption happened gradually, first in technology, which obviously improved the processes and the workflow. And then jumped in digital imaging and AI, together creating so much of change in what was such a small, dingy workplace to a workplace that looks cluttered with machinery now, where everyone is happy because the results are good, because you're doing good work. And that is the kind of laboratory that we have today for clinical pathology, with so many equipments, with so much of automation, with so much of AI now coming in slowly, that it's a pleasure to be giving out reports which you're confident about. And that is what has been the greatest disruption, that the reports that we are giving today are really credible. We are confident about them. There is repeatability, there is precision, and there is accuracy. So just like the rest of the laboratory, which prizes itself over doing very good, where your LJs are very beautiful and where your EQUAS and IQC is good. Today, ClinPath also boasts of such improvement and therefore credibility. So what has happened? And I'm only going to take you through the changes which have been important, which have been pertinent to improving this space. So first thing, most of us are aware, and this happened more than 10 years ago, was automation in clinical chemistry, in rather the urine chemistry part of the urine examination. So first we got just the strip reader, the strips, and we manually read them. And then we got semi-automated machinery, automated machinery, and now you have integrated systems. Most of this is based on reflectance photometry. The urine sample is barcoded. It's placed on the carousel of the machine, and the equipment is connected to the LIS and the HIS. The photodiode detectors pick up the reflected light, and the analog signal is converted to digital values. There's automatic disposal of used strips, which takes care of safety also. This is something that is there in almost all labs, whether you have it as a semi-automated machine or a fully automated system or as an integrated system. So this is something that most of us are aware about. What are the advantages? The procedure is very standardized. The time for the reaction is defined, and the result is read off after the completion of the reaction. The inter-observer variations, which were seen with manual reading of strips, is not there. Samples are barcoded. The machine reads the barcode, so there is no identification errors and mix-up of samples. As it is integrated to the LIS, transcription errors are also avoided. Most importantly, which I think is the clincher, is that it is subject to both internal and external quality control. And that is very, very important as far as any laboratory and any analyte testing goes. So therefore, the adoption of urine strips into doing basic urine chemistry was global. Every small lab to a large lab used it, and they were happy with what results they were. It was cost effective, it was easy to use, and the turnaround time was also managed. But still, all those which were abnormal, they had to go to microscopy, and microscopy was still manual. So the next disruption came with urine microscopy. And I'm going to talk about 3 different types that are available for us. It is completely automated today. So you have flow cell digital imaging or digital flow microscopy, which combines the quantitative counting power of traditional flow cytometry with the visual resolution of digital microscopy, which means what? In easier terms, you're combining a flow cytometer with a microscope, and therefore you're able to see the cells. So a liquid sample is injected, hydrodynamically focused into a single file stream within the flow cell. As the particles pass through the optical path, a light source, which could be bright field, dark field, fluorescence. It illuminates them, and a high-speed digital camera captures the images. And once these images are captured, then they are automatically segmented and they are identified, categorized, and it's all done in real time using a neural network software. So by feeding this sample of urine into the machine, you are getting what cells are there. You're getting pictures of the cells also. The next method is a cuvette-based digital microscopy, which is an automated imaging technology which is used to analyze urine sediment. Now, the analyzer can either automatically aspirate the urine, mix it, and dispense a small volume into a cuvette, which is specially designed. Or you may have to centrifuge the urine and put a drop of it into the urine, into the cuvette, which is specially designed, and place it into the digital microscope. Some instruments have centrifugation for a few seconds so that all the particulate matter is in a single focal plane at the bottom of the cuvette. Then there's digital imaging. A built-in motorized microscope automatically focuses and captures high magnification digital images of the sediment. Then the system uses advanced software, uses algorithms, uses AI to recognize, classify, and count the different particles which are photographed. So your work is being done by the machine, and what you would have otherwise done with your knowledge and with your experience, the cells are categorized, they're counted, and a report is generated. The next method is using flow cytometry particle analyzer. Now, this is a little familiar to us. Aliquots of urine sample are stained with fluorescent dyes that bind nucleic acids in cells and bacteria. So similar to either a flow cytometer or your cell counter, hematology cell counter. It is using semiconductor lasers, and the cells are classified by analyzing the forward scatter, the side fluorescent light, and the depolarized side scattered light. It's based on cell size, cell volume, and cell complexity, or the structural complexity within the cell. Some of them identify bacteria, and they're able to tell you whether it is gram-positive or gram-negative bacteria, which will be very helpful, especially in cases of urinary tract infection. So now there are three methods. There are three different types of equipment. In fact, there are lots of equipment using three different types of technology. And that has revolutionized urine microscopy. Today, I don't have to go to a centrifuge, put the sample of urine, centrifuge it, put it on a glass slide, take it to a microscope, and then look at it and try and identify which is a red cell, which is a white blood cell, and which is a cast, what is this cast, what is this crystal, and so on and so forth. So it's made the job easier. It's made classification of these particles easier, and therefore the turnaround time has also improved considerably. So what are the advantages? It's walkaway automation in many cases, and hence the laboratory personnel may be utilized for more resource-intense tasks. It's a closed system that mitigates the risk of splash, aerosols, contamination, evaporation, etc. Elimination of interpersonal variations due to standardization of reporting. This to me is very high up on the list. Reproducibility of reports, ratification and traceability. So as the system captures high quality digital images, you can review them long after you've discarded the physical sample. You can always change your report if you want to change, or if you have doubts, you can always go back to it and have a look at it. You can save it. It can be used even in medical legal cases. Integration with LIS, avoiding transcription errors and mix-up of samples. And most important, subject to quality control. So with so many advantages. Definitely, it is technology that has come to stay. So even if you have a very small number of samples that need to go to urine microscopy, it's worth automating it because you're doing away with all the false positives and false negatives that you can be reporting. So it standardizes. It can be used for training. It can be used for review. And so the advantages are really quite a bit. Now, with advantages come disadvantages. Obviously, the cost may be higher. The lab may have more of capital expenditure, but these are small prices that we pay for quality in any kind of system. Next, we'll try and look at pictures. Now, these are pictures which you would have seen when you're taking your sample of urine and putting it on a glass slide and looking under the microscope. The same kind of cells that are there, these pictures are captured by a camera and then they are counted, and then there is some kind of a grading system that is there, which again is customizable depending upon how you release your reports to the doctors. That is the same way you can release the reports even from automated systems. So here you have a case of UTI. So obviously you're going to see high protein, nitrite positive, and probably blood, and you want this sample to go for microscopy. So when you feed it into the automated system, supposing you don't have an integrated system, then it's going to pick up all these WBCs or pus cells that we say, and it's going to give you a number and a result which is 3 plus. So how are you going to report it in your lab is again something that the lab will determine, whether you want to say 1 nil, 1 plus, 2 plus, 3 plus, or whether you want to give it as a range. That is again customizable. And so this is how it is identifying it, and it is counting the different cells. The next one is a case of hematuria, and we are looking at the RBCs. So there are 80 RBCs and the result is 4 plus. Now, why am I calling it semi-quantitative? This is because you're putting in a definite quantity of urine sample, whether it is aspirated by the machine or whether it is put in by the technician. It is a definite quantity of the sample, and therefore you can say that per microliter or per high power field, or in whichever system that you're using, that you can grade this the number of cells that are present. So these are RBCs, and this is how I will see the RBC under my microscope also. So this is how the system, the machine will pick it up, it will count it, and it will give you a number. So whatever cells are present in the number of fields that each different machine counts, 15 fields, 20 fields, whatever, it will count all those cells and give you an average number and a total number. So cells, epithelial cells, RBCs, WBCs, and crystals. So all these are crystals which are identified. There are some systems which will tell you that this is just a crystal. There are other systems which will tell you that this is a calcium oxalate crystal, or this is a triple phosphate crystal, or this is a uric acid crystal. All this depends upon what that machine is capable of doing, how much you have taught that machine, and therefore how it can recognize. So crystal count, that is something that you and I are not doing. We are randomly giving some numbers, and your number is not the same as the number given by the other technician. Then it identifies casts. So again, it can say this is a hyaline cast, this is a granular cast, or this is, a pus cell cast, or this is an RBC cast. So it can differentiate it, or it can just count and say that there are so many casts that I am seeing per high power field or per low power field. all this is customizable. So your report from a automated machine will be the same as what you would have given if you were doing the tests manually. Only thing is this will be that much more correct and that much more with clarity and confidence. So this is another equipment on a urine sediment analyzer. Again, it's identifying the epithelial cells, it's identifying the WBCs, the RBCs, the WBCs. It is identifying a pathological cast. So each thing gets labeled. So if you're not happy with that label, you can always change the label or you can delete it. You don't have to delete, you can delete that whole screen or you can just do it yourself manually. So these are based on certain algorithms, some amount of machine learning that it has, and it is identifying the different cells, casts, and crystals that are available in your sample of urine. This is similar to identification of hematological cells. What the machine is knowing, it is identifying and it is telling you that there are 70 neutrophils in this, there are 20 lymphocytes in this. Same way it's telling you that there are 20 WBCs and there are 20 RBCs. It's up to you how you want to report it. Now, there are cases where, especially cases of hematuria, where you have ghost RBCs, which you can see here. So these are the normal RBCs and these are the ghost RBCs. So the system should also be able to identify these ghost RBCs. So if you see that on the screen, only so many RBCs are visible, whereas the machine is counting these ghost RBCs also. So it's able to recognize ghost RBCs also. These are the ghost RBCs which are being counted by the machine. So this is your phase contrast and you're able to see that these are nicely ghost RBCs, and so all that gets included. So samples with hematuria are flagged when the ratio of the hemolyzed ghost RBCs are higher than approximately 30%. So ghost RBC to normal RBC ratio is greater than 30%. Then you have a flag saying that this has plenty of ghost RBCs. And then you attach the clinical significance to it. Now, cases of hematuria, there is one cell which is very important, and that is the acanthocyte or the dysmorphic RBCs. The presence of dysmorphic RBCs in a sample of urine, which is bloody, would signify that bleeding is occurring in the glomerulus. Now, it is very difficult for us on bright field microscopy to pick it up in the lab. And we often use phase contrast. So though you can say that these RBCs are not looking okay, I cannot say with certainty that these are dysmorphic RBCs. However, when my machine has a phase contrast adaptation, then it is able to pick up these dysmorphic RBCs, and I can report the presence of dysmorphic RBCs with certainty, thereby telling my clinician that your patient is bleeding from a glomerular origin and you need to look at that carefully. Like I always say, urine examination is not something that you can take very lightly. It's like a liquid renal biopsy. There's so much that you can learn from a properly done urine examination or routine urine examination, right from the gross examination of the urine, the chemical examination, the microscopy. So if there is anything that can help you do that better, then definitely it is worth it, because you're giving the patient so much more information and you're giving him a diagnosis, and thereby he's probably getting himself treated correctly. So a small clinical pathology laboratory where I had plenty of glass slides and glass tubes, I've come a long way from there, where I have put an instrument. I can sit happily over there. I can look at all the pictures on the big monitor and decide whether the machine is saying it correctly or whether I'm saying it correctly. So I think, in my opinion, in my humble opinion, we've come a long way. Now, moving on from urine to body fluid analysis, which is another important sample that comes to the clinical pathology laboratory. Now, all of us know how body fluid gets processed in most labs. One, it doesn't reach you properly. Two, it reaches you in the wrong container. Three, it reaches you many hours after the clinician has aspirated it. It is sitting somewhere in some treatment room or in the OT. And by the time you analyze it, it's all a mess. There's either hemolysis, there's bacterial overgrowth, or the cells have degenerated. Because what we are using in many labs still is the Neuber chamber to count the cells, the WBCs and the RBCs. We count the total number of cells. We do a differential count. We do a stained slide. If facilities are available, we do cytospin. Otherwise, we try to do it on a normal glass slide and look for it. I think we should move forward. Most of the cell counters that are available in the market today allow us to do body fluid analysis. There is a separate mode for body fluid, and it gives you a much, much better method to analyze body fluids. Again, body fluids are very important, and hence you have CLSI guidelines and ICSH guidelines for the verification and performance of automated cell counters for body fluids. And CLSI tells you how you should collect the sample, when you should process it, how fast you should process it, and what you should look for when you're processing it in the cell counter. So all body fluids, when you're using the cell counter, have to follow these guidelines, and only then we can go forward from there. So the first question is anticoagulant. To do or not to do? Should I anticoagulant the sample and send it down, or shouldn't I? Now, there's a mixed bag of reactions for this. Some say just send it down, I'll process it immediately, no issues. There are some pathologists who say, no, if it's very hemorrhagic, please put it into EDTA and send it to me. So we still, at loggerheads on this. The addition of anticoagulant to CSF affects the enumeration of WBC and RBC unless it's extremely hemorrhagic. EDTA is the recommended anticoagulant for all serous fluids, and you should agitate the specimen during collection. Do not use EDTA or lithium heparin for synovial fluid, as they produce crystals that may be confused with pathological crystals. Use heparin is wrong, just omit it. So synovial fluid, again, better to send it down like that. So today, most labs get their samples in a way that their pathologist has written in the SOP, and they are happy in that way, and they process it that way. So you have to decide in your lab, what is your turnaround time for processing the fluids? How fast will you send it to the cell counter? And therefore, whether you need an anticoagulant or you don't need an anticoagulant. So prolonged transport time affects the integrity of the sample, resulting in deterioration and degradation of cellular elements. Vigorous shaking of the sample can also result in breakdown of cellular elements. The ideal time from bed to bench is less than 2 hours, preferably within an hour. Up to 24 hours if stored at 2 to 8 degrees. I don't know how many people will agree with that, but this is one of the points given in the guideline. CSF is a stat test procedure. So therefore, as soon as the CSF is collected, it better be sent down to the lab and better be processed immediately on your cell count. So how to process a sample on the cell count? So there is an SOP which will be given by the manufacturer, whichever cell counter you have. So if any pre-treatment is required, it will tell you dilute the sample or you add something. Otherwise, you just go ahead and use it neat. All body fluids require visual inspection for clots and debris before processing. This to me is the most important thing you have to do before you process your body fluid sample on the cell counter. If there are plenty of clots and if there's plenty of debris, it may be very risky to process that sample because the tubings may get clogged. So you have to be wise. You have to take a very informed decision before you process it on the cell counter. So select the mode, body fluid mode, CSF mode, whatever mode is there in your cell counter. Then you do a background check. The background check is again very important. And if your background check on the body fluid mode is not okay, wash with bleach, distilled water, or saline to clear the background. The rinse there prevents the carrier. And it's important that the background check is passed. Otherwise, you'll get unnecessary increase in the particles because you know the particle count is very, very low in body fluids. And therefore, if your background check is not okay, then there will be interference. Handling spurious results due to debris and coincidence is again something that you should be aware of. And if results are outside the reportable range, analytical range, then you may have to dilute the sample and then process it, just like we do for blood. So if you're going to process this body fluid, you're going to get a scatter plot. The scatter plot will have the polymorphs, the mononuclear cells, and in some cell counters, it will give you a highly fluorescent body fluid cells or highly fluorescent cells, which will usually be large, which will have a huge nucleus, and which will therefore fluoresce more. And therefore, it will be at the higher end of the spectrum. Now, can we really go with these differential counts? Yes, it gives you a certain idea. It gives you a trend. It gives you a direction. And therefore, you'll be able to go with it. Now, the thing here is that the pre-analyticals matter so much. If your body fluid is brought immediately, then your total cell count and your differentials will definitely be more reliable than if the body fluid sample is brought after a couple of hours, because then there will be cellular degeneration, and therefore you cannot really rely on both the total count and the differential count. So what do we get here? You get a total WBC, a total nucleated cell count. You get a total WBC count and a total nucleated cell count, and you have just a two differentiation, a mononuclear cell and a polymorphonucleus, and the RBCs, of course. Now, many of these equipments, many of these cell counters have plenty of research parameters which are not really FDA approved, and therefore they cannot be reported. But if you are processing a large number of fluids on your cell counter, then looking at these may give you a better idea of what you're doing. So, white blood cell differentiation, lymphocytes, monocytes, neutrophils, eosinophils, highly fluorescent cells like macrophages, mesothelial cells, tumor cells, and an additional count value for red blood cells with increased sensitivity. So the research parameters, like I said, cannot be reported, but they definitely give you an idea of what more is there and what you can look for when you make a smear. Now, the next question most of you will ask is whether I can just report this. That is something you must have done validation, you must have looked at lots of samples for you to have confidence to report it. It's just like reporting a differential count, just like reporting a total count. So unless you have validated enough samples, then only then you can report it with reasonable certainty. So this is how your run screen will be. You'll have the mononuclear cells, you'll have the polymorphonuclear cells, and here you will have the highly fluorescent cells. So you will get a total count, a WBC count, an RBC count, a PMN, both in absolute numbers and in percentages, a mononuclear cells in absolute numbers and in percentages. And once you get this, once there is a flag, then you will have to look at the smear and look for any cells that are foreign. Again, just like in hematology cell counters, you have to analyze the scatter plot for any abnormality. Any of these samples, it's always better to look at the scatter plot for any abnormality and then proceed to slide review. Look at the numerical values also which the cell counter is given. If nothing is abnormal, you can proceed with the report. If there is an abnormality, you make a manual slide and either review it manually, or if digital imaging is available and if it is coupled with AI, then you can go in for reporting with that. So with the cell counter, there is so much of confidence that the cells have been counted correctly. Because you know, with a Neuber chamber, there is dilution, there's charging of the chamber, then putting the cover slip, focusing on the right area, looking for the right cells, and then counting it. All of which is very, very laborious. And unless you're doing it every day, then it's very difficult for us to say with certainty that we have counted the cells correctly. So this gives you a better idea of really how many cells are there in that sample of body fluid that has come to your laboratory. So why automation for body fluids? I have spoken about it for a while. The traditional methods are all time tested from so many years we've been using that, and they are continuing to, in some is labor intensive. Training the technicians on that is very, very difficult. Subject to interpersonal variation and subjectivity, lack of QC, CV between repeat assays is high, lack of linearity studies. So automation is fast, the turnaround times are high, more accurate as compared to manual methods. It's objective, whereas that was subjective. It's subject to quality control. The CV between runs is within acceptable limits, and it has a definite analytical measurement range. So obviously, with all these advantages, which lend credibility to your reports, it is definitely a better idea to use this. So body fluids come to most of the labs, and definitely we can start with CSF. If not with CSF, especially when CSF is clear, I think it's a good idea to start with CSF. There's only one drawback, the lower limit. You have to look at the lower limit. You have to talk to your manufacturer. What is the lower limit of the total nucleated cells that can be counted in the body fluid mode, and then go accordingly. So definitely every lab that is not yet using should start with at least CSF. I want to just touch upon semen analysis. I know that in most routine labs, semen analysis has gone out of our hands and it's gone to the ART clinics and to the fertility centers. But still, we should be aware as laboratorians about the importance of doing a proper semen analysis. I mean, every test is important, every analyte is important, but semen is that much so more important. So Again, we used Neuber chambers. We didn't count properly. We didn't look at the morphology. We didn't know most of the times. We were not trained adequately. So automated semen analysis uses electro-optical systems and computer algorithms, computer-assisted sperm analysis or CASA, to rapidly and objectively evaluate the sperm quality. So with that one equipment that came in many years ago, we were at least able to freshly collected sample of semen. If you fed it into it, you can again look at the screen. You'll be able to see it did a proper counting of the number of sperms. It told you that these are the types of sperms that are available over there. And today the morphology is classified even better. And we're able to tell whether it's morphology normal, the motility is measured. And also there are equipments which measure DNA fragmentation using fluorescent dyes. Now, most of these equipment follow the latest WHO guidelines for reporting of semen samples, which makes that even more credible. So there are systems which have completely automated semen analysis reporting, which is again available for labs that get a lot of samples to process, to do semen analysis. But it's important that we're aware that automation has touched every analyte that comes into the clinical pathology laboratory.
Ma'am, Dr. Ashwini has a question. She's asking how to run the fluid if it is turbid.
If it's turbid, but there are no clots, you can run it. You can dilute it and run it one way. Okay. The other 1-in-1 dilution you can do and run, or you can, if there are no clots and if there are no big particles that you can see, you can run the sample. Shall I go on?
Yes, ma'am.
Yeah. So to sum up what I have said, the question that was asked is clinical pathology really in transition? Is there digital transformation? Is there digital revolution? Yes. Automation, digital pathology, artificial intelligence, machine learning. These are all there. And this is just to make our job easier, more precise, and more credible with a lot of accountability. AI and ML are evolving tools, and it's a learning process for us and for the machines. Now, if AI is not trained adequately to differentiate the normal and the pathological, then you and I are sunk. When urine chemistry and microscopy are integrated systems, automated result validation can also be practiced. Body fluid analysis on the cell counter should be initiated in all laboratories, especially for CSF, because it is a stat procedure and people want to know the reports almost immediately. So whether it is the pathologist or whether it is the machine, I think I still maintain that what the mind does not know, the eyes do not see, whether it's me or whether it is an AI-trained machine. But one thing I'm very happy about is today we are all in this journey together. It's a very long road. There are lots of things that need to be done, lots of things that can be done. But definitely it's a worthwhile journey. We have lots of credible partners with us who are very happy to take us on this journey. And I'm sure that in the days to come, in the years to come, there's going to be so much more revolution that it'll be a pleasure working in the ClinPath lab. Thank you very much.
Thank you, Dr. Rani, for such an amazing session and giving us such valuable insights, especially in a field like clinical pathology, as you very rightfully started, that usually it is in the back burner of the lab and in labs even till today. It definitely was very motivating listening to your talk. and the useful information and the valuable pearls that you have given. I'm sure our audience today would have definitely picked them up and will incorporate it in their practice tomorrow. We leave the floor for any questions from the audience. If anybody has any query or question or any doubt on any topic that Dr. Rani has spoken about today, please be free to ask that particular question. And we also look forward, for a quiz question from Dr. Rani as well for the audience once the discussion is over.
Dr. Renu, Dr. Srinivas here.
Yes, sir. Good evening, sir.
First,
very happy to have
good
you
evening,
here.
Good evening. Yeah, just let me congratulate Dr. Rani for an excellent presentation. And what I loved is that she has pushed everyone to think AI and the digital imaging as a co-partners, which can enhance the patient safety. So congratulations, Dr. Rani. That was a wonderful presentation.
Thank you,
Just,
Srinivas.
yeah, that's one thought. There are a lot of issues with the ECAS, okay, especially
Yeah.
for the body fluids as well as for the urine analysis. Just for the sake of the accreditation bodies, people are just enrolling with the domestic PT providers only for the chemistries, but they have left out the microscopy. Is it acceptable by ISO 15189? What's your opinion on this?
ISO 15189 has not been very clear about this. So various assessors ask you for various things. There is not one single provider that I have been very happy with in the last so many years. Chemistry, yes, to a certain extent, but microscopy, no. And again, see the microscopy, by the time you send the sample out or you get a sample, both don't work very well. So I still think that looking at digital microscopy pictures is going to be the way forward. Just like how we are doing for histopath or how we are doing for hemat, I think we should start looking at the pictures which are provided by the the digital microscope and then comment on it, because that will be definitely something that somebody has reported rather than looking at sharing samples for microscopy. This is just what I think will be the way going forward.
Yeah, that's right. The other thing is about the internal quality controls, especially for the microscopy. There are there are the global vendors for the IQCs. What we have is only for two parameters. They only give for RBCs and WBCs. The IQC does not include cast, crystals, and sometimes it does not sometimes, all the time it does not include bacteria. So is it acceptable to have an sample integrity checks every 8 hourly with the samples what we do with that of the hematology? Is it acceptable?
I don't know whether it is acceptable in the sense of the accreditation bodies. That part, I really don't know, because that is very assessor based. But see, what I think and what I like to follow is that I look for precision. Okay, so you have this sample that you're using it on the digital imaging, and you've got casts or crystals on it. Then we can do reproducibility. Okay, and 8 hourly, I don't know whether, the urine, it depends upon the size of the lab and depends upon the number of samples that we are processing. So if if your main load is only in the morning, then you want all your IQCP to be done mostly in the morning. And if you don't have samples post lunch, then there's no point doing an 8 hourly QC, if I've understood your question correctly.
Yeah, that's okay. But what my thought was that, like, suppose we have a split sample testing, which can be taken across as one part of the ECAS to make sure that we have accurate by two technical staff and two different authorized signatories, if we ever you have. And also you have an IQC, which is only looking at that of the RBCs and the WBCs of no use. The vendors should be given a feedback that they have to have the IQCs with that of the cells, crystals, and casts, so that the abnormals are also picked up. So that's my thought. And I always tell the innovators or the product developers to make sure that they'll be able to give a better IQC.
I have done that from my part, that IQC should cover everything that is approved by FDA and which is reportable.
Yeah.
This is what I tell the vendors. It will help if everybody also does the same, so that
Yeah.
the IQC samples itself can be better.
Correct. So that's it from my side, Rani. And once again, congratulations for a fantastic presentation.
Thank you, CN.
Does anybody else have anything, any kind of comment? Dr. Dr. Indira, would you like to say a few words regarding today's seminar? Any feedback from your side as well?
It was excellent presentation. I enjoyed it. And as I know her very personally also as a PG, she is very excellent in topic, I mean, very lectures. And it's a good thing that that she's concentrated so much on clinical path, which I do agree. It is the most important component of the lab.
So Dr. Rani, can we have the quiz question for today for our dear audience?
So Renu, you want one question?
Ma'am, one question or even more is fine. We'll be very happy to take whatever you give us.
Okay, so we'll have two questions.
Sure.
Okay. So the first one is, name any two methods of digital urine sediment examination. And the second one is, what controls are used for body fluid examination on cell counters?
Go ahead and please type in your comments in the chat, and we will see which are the first few comments that come correct, and we'll be very happy to acknowledge the same. Go ahead, please. Ma'am, if you could just repeat it once more, maybe.
So the first question is, name any two methods of digital urine sediment examination. And the second question is, what controls are used for body fluid examination on cell counters?
So the quiz is for everybody. Anybody can take this. Please go ahead. So I guess they're really tough questions, making people think, Dr. Rani.
No, they're very easy.
Well, go ahead.
You don't
please
have to
type
write.
in your answers. Yeah. Just type in your answers. Just take a shot. It's okay. Go for it.
It doesn't have to be fully exact. You just give two words.
We're just discussing here. So Arman, I saw you gave a thumbs up. So, maybe you could just type in an answer here. We would be happy to see that as well.
Who, me?
No. There was a person from the audience, Arman, who gave a thumbs up.
Okay.
So I'm asking him to give an answer as well. Quality controls. I think that's something we do in the lab every time. It doesn't matter if you're wrong. Dr. Sujata Udupa, I can see that you are there in the audience. So please go ahead. Please give me your answer. This is like, I'm actually taking.
If you're not answering, that means I have not done my job here.
Any one of the questions. We don't want both questions, but any one of the questions.
What controls are used for body fluids?
At least that. I'm sure we all are using controls for body fluids in our labs. So it could be anything. Just name a control which you are using, or if you're aware of, even if you're not using.
Okay, give me one advantage of digital microscopy.
Okay,
Easiest question.
That's a fair question.
Easiest question.
in your practice or in your thought process,
What do you
why do you
think?
think, why do you think that we should have digital in our practice today, right? In clinical pathology. I think there were various points which Dr. Rani had discussed, but what do you think would be pertinent according to you? Is it going to be turnaround time? Is it going to be standardization, reproducibility, accuracy? What do you think? The first person who answers this question, we will acknowledge that. Take your shot, please. Go ahead.
If I was going to give you a digital microscope today, what do you think you're going to do with it? How do you think it's going to improve your life?
Dr. Ashwini?
Can you
Dr.
get home
Shalu
at 3
Kapoor?
o'clock?
Anything. Accuracy. There you go. Very good, Dr. Shalu Kapoor. There, Arman. Accurate and precise.
That's good.
Very good. Very good. So in a way, we're looking at quality-driven diagnosis today with visual-based evidence and something which has been validated and standardized. Less that, more it. There you go.
Yes.
This is what, I mean, finally, this is what we also wanted to hear. And I think you are thinking in the right direction, isn't it, Dr. Rani? I think that's the gist of the whole talk which was there today.
Accuracy for you and lowering of the TAT for the management. Dono khush hai. Happy, happy.
Yes, I think nobody actually told about that point. Wonderful, yes. Does anybody have any other thoughts? What about education and teaching? You know, that's
Training
something I strongly support.
Beautiful tool for training.
Yeah, competency evaluation for your staff. If you just want to regularly train your staff, you know, there were times, ma'am, if you still remember, we had to call people to our microscope and tell them, you know, 3 o'clock position, this is what this is, 6 o'clock position, have a look at this. I think we're done with that today. And you can actually train in a more elaborate way, in a more accurate way, so that everybody has a perfect understanding of what is being actually told by the trainer or the educator or by the pathologist, right? And I think it's a great tool for education and training. And last but not least, let me include for research as well. I think it's tremendous amount of data collection that is going on with digital today that can be used not just for regular training. You can use that for your, you know, your conferences. You want to do your webinars, research work, delta checks.
Analytics.
Data analytics, you know, data is a gold mine today, and, you know, having all that data, there's wonderful things that can actually come out of that. And also delta checks, you know, remote access. I was waiting for somebody to talk about accessibility.
Well,
and
I said
that's
3 o'clock you can go home.
Yeah, it's a wonderful point. Yeah, gone are the days when the pathologist had to sit behind the microscope and wait for that last case to enter the lab and still sign it out and go. And what if you were traveling, you were attending a conference, you were on a holiday, and, you know, many times you take that one odd vacation and you get that call, you know, for a very important case. Well, you have digital today, you have image-based evidence, and now you're getting controls are available. Sysmex, Biorat, Dr. Shalu Kapoor, very good again. OSM, okay, that's Dr. Arman telling that OSM webinar session, ma'am, today we had. Rasha Ahmed was the person who talked about the remote work. Dr. Sujata Udupa said less stat, more reproducible. Dr. Arman, accurate and precise, and Dr. Shalu Kapoor about accuracy. I think there was some wonderful, delightful answers that we have got. Keeping in mind the mood of the session today, and these were the take-home messages. I would also like to put in of what Dr. Rani has so elaborately and enthusiastically discussed with us today. It's always a pleasure to listen to you, ma'am. We really look forward to much more discussions from your side in future. There, Dr. Shalu Kapoor has just complimented you on an excellent session. Thank you, Dr. Shalu, for that comment from your side. And as Dr. Srinivas and Dr. Indra have already told us that what a wonderful session it was today. Thank you so much for being here with us today. And it only makes it meaningful having an audience like you participating in sessions like this, and gives us the encouragement at SigTuple and motivation to have more such sessions in the future with wonderful speakers as Dr. Rani. So thank you again, ma'am. And
thank you so much. It was a pleasure, and really something that the youngsters should think about, should work on, and take it forward.
We will be having some special prizes coming up. for the participants who have given their answers for today. That was very courageous and very, and we feel more encouraged, right, to have more quiz sessions like this at the end of the session, which makes it very interactive. And I think that sometimes, in memory, we keep this, right, forever. Things we spoke in a discussion like this, or the questions that were asked. And what I would really like to compliment Dr. Rani, it's not just about the theoretical aspects that you spoke about. There's so many practical points which we don't find in books. And we only learn that through experience, and we make those trial errors all of the time. And here you are giving us those pearls, right? And I'm sure the junior pathologists who are there in our forum today would have found that very interesting to note, and will surely implement in their practice also in future. So thank you once again from everybody. And also, I would like to thank Manohar Daka, who is there behind the scenes, without whom this webinar today would not have happened. So thank you, Manohar, for making this happen as always. And we will be reaching out to all the participants who have given the answers. Manohar will be in touch with all of you. The video of this will be definitely shared with everybody in the group, and also with the people who have registered and unfortunately have not been able to participate. We will also be putting snippets of this on our LinkedIn platform. So please go and watch that space as well. And if you have more questions for Dr. Rani, she's available on LinkedIn, and you will be please feel happy to reach out to her over there as well. Thank you, ma'am, again so much. And we look forward to having you more in our future sessions.
Thank you, SigTuple. It was very nice. And here is my request to you. Body fluids is still pending. It's a long desire from the community.
Absolutely.
That we need to work on it, and work on it fast, because there's
taken,
a lot of wrong reporting happening. So please.
Point taken, point noted. And yes, we are looking into it. We will surely get back to you on that front as well. Thank you again, everybody. And we wish you all a lovely evening on behalf of SigTuple. Thank you. And yeah, have a great weekend ahead. Goodbye.
Thank you. Goodbye.